Hello, and welcome to another live broadcast with MedStar Health. My name is Karen Zingle, and today I'm joined by cardiac surgeons, Dr. Ricardo Corey, and vascular surgeons, Dr. Javira Fatima and Dr. Rajbir Valabanini, to discuss aortic disease. Even though Heart Month has ended, it's always a great time to learn about maintaining good heart health. We have a lot to talk about today. So stick around, share this broadcast with your friends. And if you have any questions about aortic disease, risk factors, symptoms, treatment options, and more, leave them in the comments and we'll be sure to answer them during the broadcast. So thank you for joining us. Before we get started, let's meet our experts. Dr. Corey, can you tell us a little bit about yourself and what you do at MedStar Health?
Hello, everyone. Thank you, Karen. My name is Ricardo Corey. I'm a cardiac surgeon at MedStar Unit Memorial in Baltimore. I have a specialty in complex aortic diseases. So I actually work alongside Dr. Valabanini, and we treat every area of the aorta from the root to the distal branches.
All right, thank you so much. Dr. Fatima, why don't you introduce yourself?
Hi, I'm Javira Fatima. I'm a vascular surgeon and I work at the MedStar Health Washington Hospital Center. I am the co-director of the Aortic Center. My specialty or my niche is complex aortic surgery. So as Dr. Corey has pointed out, we take care of everything from the aortic valve to the root to the descending thoracic aorta, thoracoabdominal, as well as infrarenal and iliac artery aneurysms. And we also take care of all other aortic pathology, whether it's acute or chronic. And I'm excited to be here to join you and spread the word.
Thank you very much. And Dr. Valabanini.
Yeah, hi, thanks, Karen. I'm Raghu Valabanini. I'm the Director of Vascular Surgery in Baltimore for MedStar Health. I also have a special interest in aortic disease and complex aortic disease. We work very well amongst our system as well as with our cardiac surgery colleagues to take care of everything involved with the aorta and the entire cardiovascular system.
Okay, wonderful. Well, thanks for introducing yourself to our viewers. Let's start with some questions. Dr. Fatima, I have some questions for you to get started. Let's just talk about aortic disease in general. What is aortic disease?
So Karen, aortic disease is a very comprehensive, very broad term that basically includes, and it's an umbrella term that includes all sorts of aortic pathology that render the aorta to be abnormal. So this could include anything from aneurysms to aortic dissections to occlusive disease, aortic valve disease, traumatic disease. Another term that often is used is the acute aortic syndrome. So that encompasses anything that's acute, that happens in somewhat of an emergent situation or urgent evaluation is required, and then consideration for surgical intervention is considered. So these can be acute dissections, these can be symptomatic aneurysms, ruptured aneurysms, patients with traumatic transections of the aorta, PAUs, which are the penetrating aortic ulcers, or intramural hematomas of the aortic segments, which is called the IMH. So that's a very broad term of anything that's not normal or not right with the aorta.
Okay, thank you very much for explaining that. What are the different types of aortic disease and what type of physicians treat each?
So, when you're talking about aortic diseases, you can kind of divide them based on the pathology, kind of like what we've already sort of reviewed in the different aneurysms, dissections, IMH, PAUs, traumatic. But when you're talking about what type of physicians will treat them, it a lot depends on the actual anatomic location of these aneurysms or pathologies. So if you're talking about the root of the aortic of the aorta itself or the ascending aorta, that generally lies in the realm of the cardiac surgeons, as well as the arch. But now when you're talking about the different forms of treatment, you're talking about endovascular approach versus open approach. So for most part, when we're talking endovascular approach, there's a lot of overlap and a lot of collaborative effort that goes into repair of the arch pathology. So we're very fortunate to have an amazing and collaborative integrated cardiovascular collaboration that allows us to treat the patients with the best treatment possible just by virtue of the fact that we work together. And if the patient's best treated with open for ascending and arch stuff, then we have the cardiac surgeons take care of it. If it's something that requires endovascular approach, then the cardiac and vascular surgeons work together to take care of it. Now, if you're talking about the thoracic, descending thoracic, or talking about the abdominal aortic aneurysms, while largely they do fall under the purview of the vascular surgeons. But again, when we have endovascular approach to these, the cardiac and vascular surgeons work together to make sure we can offer our patients the best possible treatment.
That's wonderful. Thank you so much for explaining that. What about the most common aortic disease? What's the most common type out of the ones that you mentioned?
So, again, it depends on the anatomy and the location. So if you're talking about the ascending or the aortic arch or the thoracic aneurysm, the most common generally tends to be the aortic valve and ascending aortic involvement. Now, those comprise about 60% of all thoracic aortic pathology. 40% of the thoracic aortic pathology is confined to the descending thoracic aorta. Now, if you're talking about the abdominal component, while most of those aneurysms or aortic pathology tend to be in the infrarenal segment, about 20 to 30% of them are pathologies that involve the arteries of the kidney or the intestine or the liver, and tend to be some of the more complex aneurysms that we call the thoracoabdominal aortic aneurysms.
Okay, thank you so much. Can you explain to our viewers how they would know if they have aortic disease?
So aortic disease generally is a very silent disease. People can have aortic aneurysms for years and never know about it if they've never had any sort of imaging that would reveal that. Sometimes, however, they will present with consequences or complications of these diseases. So, or have acute presentation, which would entail shortness of breath or severe pain, or sometimes they will have syncopal episodes. So some of these can present, when they are ready to present, they're usually pretty dramatic in their presentation. For most part, they remain silent.
Okay. Can you talk about what aneurysms are, and can you explain the difference between the types of aneurysms?
So aneurysm basically is a term that is used to describe the abnormal dilatation of the aortic wall that results in ballooning of the aorta. Now, anything that's greater than about 1.5 times the normal size of the aorta is considered an aneurysm. Not all these aneurysms need to be fixed right away. So when we're talking about these, when they reach a certain threshold, and the threshold varies from the different segments of the aorta in which they're presenting, then they meet criteria for repair, and intervention is warranted at that point.
Okay. Dr. Fatima, thank you so much. I'm going to move over to Dr. Valbanini. Let's talk about risk factors. So we learned about aortic disease, the different types, how someone would know if they have it. Can you talk about risk factors for aortic disease? What are they, the most common?
Sure, Karen. So there are some risk factors that we can control and some that we can't. The most common risk factors for aortic disease are age. As you grow older, your aortic wall tends to be weaker. Genetics. If you have a family history of aneurysm somewhere in your body, there's a higher risk that you may have one, especially if the person with the aneurysm is a woman. It's more likely to be given to their children. High blood pressure. Keeping your severe stress with high blood pressure causes stress amongst the aortic wall, which may cause that ballooning or dilatation that Dr. Fatima mentioned. One of the biggest controllable risk factors is smoking. Smoking has been shown time and time again to cause damage to the aortic wall, and potentially in some patients cause that development of aneurysms. The other one is being male. Men have a higher likelihood of having, especially in the abdomen, aneurysms than someone who someone who's female. So if you are an older smoker who's a man and has a family history of aortic disease, you're at somewhat of a elevated risk of developing an aneurysm somewhere in your body.
Okay, thank you very much. So you talked about the risk factors of stress leading to aortic disease. You talked about the hereditary nature, the gender differences. Wanted to talk a little bit more about the stress factor. Is it severe stress? Is it common stress? Can you talk a little bit more about how stress can lead to aortic damage?
So the way that our body relates to stress, whether it is emotional stress or just stress at work, is higher blood pressure. And elevated blood pressure is, especially severely elevated blood pressures, could cause aortic damage to the point where aortic dissection is commonly caused. And an aortic dissection is when there's a tear in the aortic wall. And that tear is usually caused by elevated blood pressure, causing severe stress on different aspects of the aortic wall, causing it to tear within the wall. So controlling someone's stress levels, keeping their blood pressure controlled, especially if someone has a known diseased aorta and it's somewhat dilated, keeping your blood pressure controlled is very important to help prevent the tear in the aorta from happening from that elevated stress.
Okay, thank you very much. And you talked about, from a hereditary standpoint, the mother could pass it along to their child. What about other hereditary factors, or is that really the most common?
Those, there are also a lot of connective tissue disorders that people have where especially if they have aneurysms in younger patients, that can be transmitted from their parents. And common ones such as Marfan syndrome, Ehlers-Danlos, Loeys-Dietz are common names for these hereditary connective tissue disorders. So, and there are also some things that we don't know the name. We haven't had a name to the reason why some families transmit aneurysm, the gene that is responsible. There are multiple genes that can cause aneurysms to develop. So there's some people who just, if they have a family history of aneurysms, especially if on the younger side, they're more likely to have it in their children have aortic disease as well.
Okay, thank you very much. Can you talk again about the gender differences and those risk factors? You mentioned male and female risk factors. So can you touch on that a little bit more?
Sure, Karen. So in the abdomen, abdominal aortic aneurysms are much more common in men. When you get to the more extensive aneurysms throughout the body, from the chest into the abdomen, the thoracoabdominal aneurysms that Dr. Fatima mentioned, those have a relatively equal occurrence between genders. However, women, because in general their aortas are smaller than men's, tend to rupture at a smaller size than men's do. So there is a gender difference in the risk factor if you have an aneurysm of a rupture if you are a woman as opposed to if you are a man. And also at a smaller size. So one size doesn't fit all between the genders.
Okay, that's very interesting. Go ahead, Dr. Fatima.
Karen, I would also add that, generally women, when they present with ruptures, they tend to have far more complex anatomy as well compared to men. And I think we see that primarily, as Dr. Vallobanini pointed out, that women, their aortas may rupture at a smaller diameter. But sometimes if we're waiting for the same criteria as men, by the time they get to that size criteria, they've already had further degenerative processes of the aneurysm that make them more complex in terms of their anatomy.
Wow, that's very interesting. Thank you so much for explaining that. Dr. Vallobanini, I have another question for you about, this is piggybacking off of what Dr. Fatima said when we were talking about how someone would know. Can you talk about warning signs or symptoms of aortic disease?
So unfortunately, like Dr. Fatima mentioned, aortic disease is typically a silent disease unless it's a very complicated, life-threatening problem. So the two main types of aortic disease, which are aneurysms, which we've been mostly speaking of, they don't typically cause symptoms until they're about to rupture. And the symptoms that can present at that stage would be severe, depending on the location of the aneurysm, severe abdominal pain or back pain because the aorta is located near the spine in the back. If it's a abdominal aneurysm, if it's an aneurysm in the chest or in the thoracic aorta in the mid-chest area, that could present a severe back pain behind the shoulder blades or severe chest pain. Or if it's closer to the heart, severe chest pain. So, and again, if you may have a large aorta and not know what it feels like, and not know that you have it because it doesn't feel like anything unless it's about to rupture. Now, if someone has a dissection, which is a tear in the aorta, and depending on the location, it could present a severe chest pain or back pain, but could also present as severe leg pain or inability to move the legs because the tear in the aortic wall actually shuts down blood flow or can shut down blood flow to your legs or your vital organs. So if you are having symptoms from aortic disease, it's a big problem. Typically, most aneurysms are detected, thankfully, by imaging that you're getting for something else. So let's say you're having an abdominal pain, and you might have like gallbladder disease. Someone gets a CAT scan and they can find an aneurysm. We could talk about it more later. There is screening that can be done for aortic disease that has some guidelines for the infrarenal aorta, but for the most part, it is a silent disease.
Okay, thank you so much. Dr. Corey, I have some questions for you now. Let's talk about other heart conditions, and this is also really piggybacking off of kind of risk factors. Do having other heart conditions increase your likelihood of getting aortic disease?
Yeah, the short answer to that is yes. And the first one I would start with is something called a bicuspid aortic valve. The reason why I mention that is because bicuspid aortic valve is actually very common and seen in about 2% of the population, estimated to be in about 2% of the population here in the western part of the world. And what that means is that normally the aortic valve has 3 leaflets, but in patients who have a bicuspid aortic valve, they only have 2. And those patients are more likely to develop aortic aneurysms as they get older, and it's believed to be due to how the valve distorts the normal blood flow. So that's one group of patients where we see aortic aneurysms develop. Aortic aneurysms are also found along with other abnormalities. They're associated with other abnormalities. So people who have abnormal branching of the branches that come off the aorta, something that's called like a bovine aortic branching, they tend to have aortic aneurysms as well. People who've had previous congenital disorders or were born with certain abnormalities, such as aortic coarctation. They can have aneurysmal development later in life, and also patients who are born with other heart abnormalities, either with the valves or the chambers of their heart. It can develop aortic aneurysms later in life.
Okay. Thank you very much. Is there any way to prevent an aortic aneurysm or keep it from worsening?
Another good question. Unfortunately, there is nothing that we can do to prevent this disorder. But there are things that we can do to help treat and manage and maybe even slow the growth of that dilating aorta. And this is where the multi-team approach, multi-physician approach can be helpful. So one of the things that we can do is actually manage high blood pressure. So keeping your blood pressure well controlled, staying on top of your medications, that's one of the most important things that you can do. As Dr. Valbenini mentioned, lifestyle choices are also important, specifically in this case, smoking. If you're someone who smokes and you have an aneurysm, that can be a very dangerous situation. So if you do smoke, quitting that habit can help you tremendously in preventing further damage to the aorta. There are also certain medications that have been studied that have shown to correlate with a slower rate of growth. So in patients who have Marfan syndrome and they were taking a group of medications called the statins. That's a type of medication that lowers your cholesterol. That's been associated with slowing the growth, as well as particular types of blood pressure medications called the ARBs. So this is where it's important to work with your physicians, your cardiologists, to be on the right medications to help lower the risk of having an event with an aneurysm.
All right, thank you very much. Wanted to talk more about screening. How do physicians screen or diagnose aortic disease? Dr. Valbenini started talking about that a little bit. Can you expand on that?
Yeah, and as Dr. Valbenini mentioned, a lot of times this is just discovered incidentally, and that's because, as was previously stated, there are no symptoms or warning signs that you have this disorder until something bad is happening. So because there are no signs, people in general are not looking for it. However, if there are certain things that have been picked up on, such as a family history of aortic disease or sudden death, some physicians will actually look for this. And one of the more common screening exams that they can do is something called an echocardiogram. And that's basically a very high-tech ultrasound of the heart and the root of the aorta that comes out of the heart. So that's one way to detect abnormalities, particularly in the aortic root. If we want to go to further screening, we can do CT scans. CT scans of the chest or abdomen and the abdomen to look for our aneurysms in any location along the aorta. You can also do an MRI study if you're not able to get a CT scan, although that is more time intensive. So there are several studies that we can do to look for this, but it starts with any kind of suspicion. Is there a physician who has a suspicion that I need to look for an aneurysm in a particular patient?
And just to add on to that, what Dr. Corey is mentioning, in the infrarenal abdominal aorta, because of the risk factors that's mostly male, everyone's welcome to Medicare visit. The U.S. government has allowed for a screening of abdominal aortic aneurysms in people who are male, over the age of 65, and has a past history of smoking. And past history of smoking means as little as 5 packs of cigarettes in their lifetime. So it's a large portion of men who are available for screening. In my opinion, I think women who have the same criteria, even though that does not necessarily meet societal recommendations, my patients I do screen if they have a history of smoking, women patients as well who are over the age of 65, especially if they have other vascular disease, and really if they have a family history of aortic disease as well.
Okay, thank you for that. We've talked about a lot of things already. We still have some more questions for you, but want to take a moment to remind our viewers, if you have any questions for our experts, please post them in the comments. We're talking about aortic disease with cardiac surgeon Dr. Corey and vascular surgeons Dr. Fatima and Dr. Valabanini. If you haven't already, give us a like, let us know you're watching, and share this broadcast with your friends and family so we can help spread awareness around aortic disease and educate our community about this disease. So let's continue. We have some more questions. We're going to talk about aortic disease treatment now. Dr. Corey, I'm going to continue with you. Will you talk about the treatment options for aortic disease?
Certainly. So in general, I break the treatment options down into two large groups. When you're continuing with observation, in that group, I would put medical management. So that includes blood pressure management, being on an anti-cholesterol medication, and having studies, whether it be once a year or once every 2 years, to look for continued growth in the aorta. And that's for patients who have not had any complications and are not at a size where it needs an intervention. Now, for patients who need intervention, again, this is where the multidisciplinary approach is helpful, because we want to make sure that we provide the best treatment options for all patients, depending on the type of aneurysm and where it is. So some patients may require, on one end, an open surgical repair. And that can include patients who need an aortic root repair or root replacement. They may also need the aortic valve replaced. And that in general will be a surgical repair, and that involves open heart surgery. Same thing for most cases of ascending aorta repair. When we look at aneurysms in the arch and the descending thoracic aorta, that could involve either open repair, or it could involve endovascular repair, which is much less invasive. Patients tend to recover more quickly from an endovascular approach. And some patients may require a hybrid, a combination of both an open or endovascular repair. So having experts in both fields is quite advantageous to the patient. Same applies to the abdominal portion. You may need an open or an endovascular repair. The technology has come quite a long way, and a lot of these can be repaired without involving open surgery. So being at a center that has experts that can operate at all levels of the aorta and who work together, who discuss treatment options, and then come up with the right tailored option for each patient is quite important.
Okay, thank you very much for that explanation. Let's talk about new guidelines for aortic disease that were recently published. Can you talk about those, what those mean for our, what they are, what they mean for our patients? And if patients have been told that they have an aneurysm, but it wasn't an operable size, based on those new guidelines, should they reach back out to their doctor? Will their doctor contact them? Can you talk about that a little bit?
Certainly. So the field of aortic disease and aortic disease management is one of those areas in medicine where the knowledge has really grown significantly over the past 40 to 50 years, and the knowledge and the capabilities are accelerating even more now. The most recent guidelines that were published are an update to the guidelines approximately from 12 years ago. And, there's more evidence based on the knowledge that we've gained. So for patients who have any type of aortic disease, the things to know is that, yes, there is consideration for earlier intervention now. And the reason for that is because, some of the data that we've gathered over time has shown that there are complications from these aneurysmal disease that can arise at a smaller size than we previously were treating patients. Now, for patients who have an aneurysmal disease, it's still important to talk to an expert because not everyone who has an aneurysm needs to have a repair right away. There are certain other factors involved. For example, we know that patients who have certain genetic abnormalities may be at a higher risk. So we hear a lot about the common syndromes such as Marfan syndrome, Loeys-Dietz, Ehlers-Danlos, but there are other genetically related abnormalities that can cause aneurysms. And those patients may need intervention at an even earlier point in time. We're talking about maybe 4 or 4.5 centimeters, depending on which type of mutation they may have. So this is where the multidisciplinary approach comes in again. If someone has an aneurysmal disease and they have certain other risk factors, they may need a genetic screening and genetic study. And that's part of the guidelines, having a multidisciplinary team evaluation to determine what an individual's risk factor may be for having complications. So it's not very straightforward, as just having an aneurysm and being at a certain size will determine when you get an intervention. Certainly, if it's a very large aneurysm, then yes, but there are multiple factors that have to be considered. So the new guidelines do take that into account. It also looks at patients who may have certain inflammatory disorders and how those are associated with aortic disease. It also gives information about how we do surveillance, how often we do either a CT scan or an echocardiogram, how often those patients should be followed. And then it also talks about some of the latest treatments, specifically for treating blood pressures and other abnormalities like high cholesterol in patients who have aortic disease. So the key here, though, is that you want to see someone who is an expert in this field, who has the most up-to-date information and can help guide your personal treatment. Because as Dr. Valbanini and Dr. Fatima mentioned before, one size does not fit all.
Yep. Thank you very much. Really appreciate those insights. Let's go back to Dr. Fatima now. Let's talk more about surgical options as a treatment. Can you talk about what happens during surgery to treat an aneurysm?
Yes. So, as Dr. Corey has already pointed out, there's certain size criteria that need to be met. And there's several considerations that go into when is the right timing for a surgical intervention. In addition to that, it also depends on what type of surgery is warranted. So here we review all our patients at our aortic conference, and we determine what is the best modality to treat the patients, whether it's open or endovascular. Now, a couple of things that help us decide is the anatomy of the patient, what is feasible, what is doable, and what would be the most durable long-term option for the patient. And in addition to that, another consideration is the physiology of the patient. What will they tolerate? What will they do well with? What is their body's ability to do well with? So if you go for an open repair, so let's say there's a patient who's fit and healthy and can tolerate an open repair, then that is what we would offer that patient for an infrarenal or a juxtarenal, which is close to involving the renal arteries. So those patients will get an incision. that will get us access to the aneurysm, and we replace the aortic aneurysm or the aortic pathology that we're dealing with. Now, when patients are not very healthy or they have medical illnesses that preclude them from being good candidates for an open repair, in those patients, an endovascular repair can be entertained. And for endovascular approach, we do them largely percutaneous, which means that they don't have any incision at all. So as you can imagine, that is so much better tolerated by the patients. And a lot of these patients, depending on the extent of aneurysm coverage or the aneurysm itself, may go home the next day or in a day or two. So that really has changed the game of the aortic repair, and has made it a lot easier for the physicians to offer treatment to patients who sometimes otherwise may just get boxed out of any treatment if we're only reliant on an open repair. So I think that really has made a big difference in the management of aortic aneurysms, especially in the more complex aortic aneurysms, and in the older population of our community who may have multiple medical problems that make it harder for open repair.
Yeah, I think
All right.
definitely that to tag on to what Dr. Fatima was saying is that patients, when I started training, who we would not be able to offer surgery to, were able to offer surgery with minimally invasive endovascular methods, and they're able to tolerate it quite well. So there's no ageism in treatment of this disease. We look at the whole patient, their individual physiology, not just their age, when evaluating these patients.
Makes sense. Thank you. Dr. Fatima, let's talk about other treatment options other than surgery. Let's talk about medication. Are there any medications used to treat aortic disease? So as an alternative to surgery, and what do those medications do?
You know, aortic aneurysms are primarily a surgical problem. Can we use medications to help the progression of aneurysm if they are smaller in diameter and size and don't meet criteria for repair? Then absolutely. As Dr. Ricardo had pointed out earlier, the use of medications to lower the blood pressure, to reduce the level of stress on the aortic wall, some beta blockers and calcium channel blockers and cholesterol lowering medications are definitely treatment options that should be provided to all patients with aneurysms. But once the aneurysm meets criteria for size, which sort of is like a risk-benefit ratio in these patients, then it is really a surgical treatment. There is no medication that we have that will make the aneurysm go away. We don't have that at this point. There are clinical trials that are ongoing to reduce the progression or to halt the progression of aneurysmal disease, but I don't think we have anything that'll reverse it.
Mm-hmm. Thank you very much. I have a few audience questions that I would like to ask. The first one is for Dr. Valabonini. You talked about the testing and screening on patients who were previously or current smokers. Can someone request to be screened for an aneurysm, and can they request this of their primary care physician?
Yes, of course. The screening typically is an ultrasound examination. So either of the chest or the echocardiogram, like Dr. Corey mentioned before, or the abdominal ultrasound that I was mentioning, which is mentioned. If you have risk factors, it's definitely recommended to get screening, especially if you're over the age of 65, have a family history of aneurysms, history of smoking. And, like I mentioned, male, especially male, but also female, I think these all should definitely be screened. Another thing that, we talk about family history. If you have a family history of sudden death and there's unknown reason, especially at a younger age, that should also, think that potentially that could have been an acute aortic syndrome that caused that death. So in those cases, especially at a young age and you're not really sure what happened, I would get screened as well.
And I would also add one more thing for the women in our community. While the U.S. Task Force guidelines primarily states male patients with all the criteria that Dr. Velabanini's already pointed out, fortunately, the Society of Vascular Surgery has put out newer guidelines that also endorse screening for women. So please don't feel like you need to be left behind. If you have any of the risk factors that Dr. Velabanini has mentioned, please reach out to your primary care doctor. And I'm sure if they'll if you mention the Society of Vascular Surgery guidelines, it is in line with that to screen women for aneurysms as well.
Okay, thank you very much, Dr. Fatima and Dr. Valbanini. I have another question. I'm going to send this one to Dr. Corey, another audience question. Do vascular surgeons and cardiac surgeons treat aneurysms together, and which specialists treat which type of aneurysm and dissection?
Yes, that's a very good question. So yes, in centers like ours, where we have a comprehensive team, we do treat this disease together. We look at the patient, we look at the anatomy, how extensive it may be, and then we decide what would be the best treatment for this patient, how much they can tolerate, and what would allow us to treat as much of the disease as possible. In general, aneurysms that involve the aortic root and ascending aorta, those will involve surgery by the cardiac surgeon, because that requires cardiopulmonary bypass. While we will work together again, as long as we know the patient can tolerate the operation, that will be a surgical operation. For patients who have aneurysms in the arch and the descending thoracic aorta, they actually may need a combination of both surgical specialties, and we offer that also. So they may need an open surgical repair initially to repair a part of the arch, and then we do endovascular work. Sometimes, though, we can do it all just by doing endovascular management. Again, it depends on the disease and how extensive it is. And as Dr. Fatima mentioned before, the abdominal portion, that can be either surgical or endovascular. That's usually done by the vascular surgeons. A lot of times you still see overlap, though, in the descending thoracic aorta, and even here at our institution, both of our specialties will do those endovascular procedures in the descending thoracic aorta together. So there is a lot of overlap, but the goal, again, is to provide the best treatment.
Yep. Thank you very much for that. And thank you to our audience for those questions. Dr. Valbanini, I want to ask you about surgery after, or what happens after surgery for an aneurysm. Will it ever come back? Are there any risks that our viewers should consider to that surgical option?
Yeah, so when you have surgery, you're treating the aneurysm that exists. Development of aneurysm disease is, it's sort of like a cancer where that it can be developed in any part of the aorta later on down the road. So for example, if you fix infrarenal aorta below the kidney arteries in the belly, that doesn't mean that the area right above where you fixed in 10 years isn't going to grow and degenerate. It doesn't mean that your ascending aorta near your heart is going to grow and is not going to grow and degenerate. So surveillance is very important. Most importantly, in endovascular repair, we're putting stents in, because when we put the stents in, the ability of that repair to stay adequate means that there's no enlargement where the stent is attached above or below it, because that could cause a leak. So there's more follow-up in the minimally invasive repairs, the endovascular repairs. But aneurysms could develop anywhere in your body. And if you do find an aneurysm somewhere in your body, it's important to look in all the other common places Just today in my clinic, I had a patient who I've had several patients who I'm following for abdominal aortic aneurysm. I found an ascending aortic aneurysm that I'm going to send to Dr. Corey, who needs repair. Another patient had an abdominal aortic aneurysm and an iliac, which is a pelvic artery aneurysm. And routine screening, I checked for an aneurysm behind their knee, and I found that. So it's very common to find aneurysms in other areas. So that's why, as vascular surgeons and aortic specialists, we generally tend to follow our patients because there may be problems down the road.
And that's why I tell my patients that we're going to be friends for life, because this is a long-term relationship that we build with our patients to make sure we continue to provide excellent care to them and not miss any of these aneurysms that may pop up.
Yep. Great. Thank you so much for that. And Dr. Valbenini, what about risks for surgery? Can you talk about that?
With any surgery, there are risks. With open surgeries, especially, they're probably more riskier in the short term with the increased risk of dying right around the time of surgery, but still it's relatively low. When you do minimally invasive repairs, there's a lower risk of dying during the surgery, and also lower risks associated with surgery. But aortic disease is like major surgery. Just because we're putting a stent in, it's not the same type of stent that people put in your heart where you feel great and leave the next day, or the type of stent that we leave in the legs. The stents are actually quite large, so it's still somewhat risky surgery, and so I don't take any of the surgeries lightly. There is a small risk of dying or bleeding or having a stroke with all of these surgeries. What aortic specialists try to do is we try to balance those risks with the benefit. So we look at the individual patient and we determine whether if your risk is too high and we think that probably you're going to die from something else besides your aneurysm, we're not going to offer repair of your aneurysm. But if you're relatively in good health and your benefit is higher of living more than a couple of years, then the aneurysm is likely going to, if it meets the size criteria, is likely going to be the cause of your death. So we try to balance that, and it's a conversation with the patient, what they want and what we think their risks of dying from the aneurysm are versus the risks of dying. So it's definitely a conversation we have with their patients. So it's not the riskiest surgery, but it can be. And so it's definitely a conversation with both the aortic team of specialists, but also the patient and their families.
Right.
And their desires are to tailor the right treatment to the right patient.
Sure.
I'd like to add
Go ahead,
one
Dr. Corey.
thing.
Yeah.
Yeah, sorry about that. Just wanted to add that in general, our knowledge, medicine, medications, anesthesia have come a long way. And in general, surgery is actually a lot more safe than what people may imagine or what they may know from the past. So all of these procedures that we've spoken about, even though they're quite complicated, we have learned a lot about how to manage patients safely and how to get even the most complicated patients through the most complicated operations. Again, having selected them, for the right procedures, and as far as the complications or the outcomes, those have improved tremendously over the past 20 years or so.
And I would echo everything Dr. Valbenini and Dr. Corey have said. And I would just say that, this also highlights the importance of having the multidisciplinary team, the aortic team for taking care of these complex patients, because it's not only about the surgeon, it's about the cardiovascular anesthesia team, the OR team, the nursing team, the ICU team, The entire team that takes care of the patient from the time we meet the patient to operating on the patient to taking care of them postoperatively and to their follow-ups. So I think it's an entire team's effort that leads to success. And it's very important to have these multidisciplinary aortic teams to optimize the outcomes for our patients.
And I think that's definitely a real strength of our program here in MedStar Health, in that we do collaborate. It's not like that at every institution, but they're daily conversations. We have weekly conferences where we go over patients with throughout the system, from Washington, D.C. to Baltimore and the surrounding areas, both the cardiac surgeons, the vascular surgeons, and also, we want input from the patient's cardiologists, their primary care doctors, and we try to keep everyone in the loop, and especially the patients and their families as well, to come to the right decision and how to treat them.
Yep. Thank you very much for that. That is really great insight and perspective. Hearing about the post-surgery approach, what you all do after surgery, having that continual conversation with our patients. Dr. Corey, can you talk about how often patients see their physicians post-surgery to make sure there's no other issues or aneurysms in other areas of their body, like Dr. Baldanini mentioned?
Yeah, so initially, after an operation or any type of intervention for an aneurysm, we'll see our patients multiple times within the first 6 months or so. One, just to make sure that there are no complications, and two, to make sure that they're recovering well. So, they'll be seen sometimes at 4 weeks initially, sometimes earlier than that. You may see them at 2 weeks and then 4 weeks. Then, we may do imaging, usually a CT scan at about 3 months, and then they'll be seen again at 6 months. So there's definitely very close follow-up. It also varies depending on the surgical approach, whether it was an open operation or if it was done endovascularly. And after that, we'll usually continue to see our patients on an annual basis, because as my colleagues pointed out earlier, aneurysms can continue to develop. They can also have changes in other areas of their aorta. So it's important to follow these patients long term, and usually that's an annual visit. If a patient has demonstrated stability for an extended period of time, we may see them every 2 to 3 years or so. But again, that depends on the type of disease they have and where they have it. Also depends on if there's a genetic component. So we take all these factors in mind, but the short version is we continue to see our patients for a long time.
Yeah, that lifelong friendship, right, Dr. Fatima? That's wonderful. Thank you. Thank you, Dr. Corey. Let's wrap up. I want to ask you about clinical trials and advancements in aneurysm treatment. Dr. Fatima, I'm going to start with you. Are there any clinical trials underway for aortic disease?
Oh, absolutely. We're in the era of advancing the aortic technology, and we have a lot of clinical trials that are catering to the aneurysms that are in the infrarenal region, in the thoracoabdominal region, in the aortic arch region. So, specifically talking about the aortic arch, we are now coming up with devices that have ability to treat the aneurysms of the arch with single branch device or dual branch devices. And we at MedStar are part of at least 2 of these clinical trials that allows us to take care of patients who may otherwise be unfit to tolerate an open repair. Additionally, we are also part of clinical trials that are involving the thoracoabdominal aortic aneurysms. We are currently part of 2 of those clinical trials, and we have our own clinical trial device and investigational device exemption that is FDA approved. And there's only 11 IDE, these are called the IDEs, 11 IDEs that are approved by the FDA nationally. And we have one of these IDEs here. So with that, I'm able to fix the aneurysms in the areas that involve the mesenteric artery, the intestinal artery, the kidney arteries, because some of these are very complex surgeries, and it reduces the amount of stress on the patients. So it really has been a huge step forward for us to have access to these devices that we can modify and create, tailor them for each individual patient. So I think that's been a huge advancement in the terms of innovation and research that is required to provide care for our patients. So we're very fortunate. We have an excellent research infrastructure here that allows us to carry on these clinical trials and provide our patients with the most cutting edge technology out there in the realm of the aortic diseases.
That's wonderful news. Thanks for sharing that. Dr. Valbenini, what other advancements are on the horizon for aneurysm and aortic disease treatment?
I think, similarly to the way that aortic valves have been, treated with minimally invasive procedures, we're approaching where we could almost treat any area of the aorta. So probably in my career, in the next 10 15 years, we'll be able to treat any aspect of the aorta with the minimally invasive stent technique to help provide our patients better outcomes. Also, with the advent of genetic personalized medicine, potentially we'll be able, there are a lot of people trying to figure out how to halt aortic disease development medically. So we're still a ways away from that, but potentially there's exciting research coming in that area as well.
All right, thank you so much for that. Let's wrap up with some closing thoughts. What, Dr. Corey, I'll start with you. What is there anything else that you'd like to add or reemphasize that we talked about today that you think is important for our audience to take away from today's discussion?
Yeah, one of the things that I would like to convey to the audience is the importance of knowing your family history. Even if you're not in the medical field, you don't have to be medically sophisticated. Just to ask some, simple questions and know a bit more about what your family history might be, because that has proven to be very important. And, I know for us as clinicians, we learn some very surprising details. And, after we start asking our patients questions, and then they go back and ask their family members questions. So it's important to communicate with your family, learn more about your family medical history, particularly, people who may have died. One of the common things that we hear is that, there may have been a parent or a grandparent who died of a heart attack. But it turns out they were very young. They actually never heard of having any kind of heart disease. That's actually an important piece of information for us. So, because in a lot of these cases, it's not that they had heart disease. It's not that an autopsy showed that they had this. So just knowing more about your family history and your immediate family members who may have passed, if you know a bit more about what happened to them, that can be helpful, and to communicate that with your physicians.
That's a great takeaway. Thank you very much, Dr. Corey. Dr. Fatima, what would you like to reemphasize to make sure our viewers know before we wrap up today's discussion?
I think I would just say that, once you've had treatment for your aortic disease, that's not the end of the road or the relationship with your vascular surgeons. Please make sure you follow up, because there can be problems down the line. New aneurysms can pop up, or there could be further degeneration of the aorta above the repair that's been done. So these are long-term relationships. Please follow up. And if you have any questions, any concerns at any point of time, we're here. Please reach out to us. We're happy to help take care of you, guide you, and do whatever is necessary to provide you the best care possible.
Thank you, Dr. Fatima. Dr. Valbenini, anything you'd like to add?
Yeah, I would just like to say get screened, especially if you meet any of the criteria. If you are a former smoker who's over 65, get screened. It's a painless test that can save your life.
That is great advice. Thank you very much. Well, that's all the time we have for today. Thank you for joining us today. Thank you to our experts. We covered a lot of wonderful information. This will be available for replay if you didn't catch the broadcast live. If you would like some more information about aortic disease or would like to schedule an appointment with us, you can call, if you're in the Baltimore region, you can call 410-554-2950. And if you're in the DC region, you can call 202-877-0275. We'll publish those numbers in the comment section. Thanks again. Thanks you to our viewers and for our experts for being here today. We'll see you next time.
Thank you,
Thank you,
Karen.
Karen.